everybody. Welcome to Eat, Move, Think. Today's episode is a really special one for me because I am joined by one of my clients, Norma Pasquale, who has been with me now for about a year,
yes,
right? As part of the Perimenopause and Menopause program here at Medcan. Hi, Norma.
Hi.
How are you today?
I'm great. Thank you so much for having me.
Oh, thank you so much for being here. I know I really appreciate having a chance to ask you about your story. And I know that our audience is just going to get so much out of today's episode. You've really experienced the gamut of menopause transition symptoms. And this is going to be such a unique episode because it's an opportunity to highlight some of the symptoms that people may not associate with the menopause transition and yet are strangely common. So we can highlight some of those, but also just to walk people through sort of start to finish your journey from really struggling to, as you said to me so aptly, sort of getting your mojo back, right?
100%.
Feeling
Yep.
like you're back to yourself.
Yes.
So just to set the stage, like many, many women out there, Norma is a part of the workforce. And according to a landmark study put out in the fall of 2023 by the Menopause Foundation of Canada, there are about 10 million people in the workforce in Canada, and about 25%, 1 in 4, are women over the age of 40. Now, we know that about 80% of women experience some degree of symptoms when they go through the menopause transition. So by far, the vast majority will experience some symptoms. And yet, less than 15% of women receive any sort of treatment for their menopause symptoms. The burden of untreated menopause symptoms is costing the Canadian economy $3.5 billion a year in reduced work time, lost days of work, and overall loss of productivity. So this is actually a crisis, a financial crisis, and more so a personal crisis for the women who simply are not being given appropriate treatment for their symptoms and are suffering. As a result, 1 in 10 women is leaving the workforce, turning down that promotion, scaling back their hours, or leaving entirely. And 1 in 5 is thinking of quitting. So we really do have to address this. And so with that in mind, why don't you start by just telling us a little bit about yourself, what life was like before you started through this menopause transition?
Sure. My life was very active. I loved going out for walks, exercising. I have my own business as well, which I was very busy with, and just doing everyday, I guess, normal things. And then slowly things just started changing for me. Not even thinking about my menstrual cycle, but then those slowly started to change. And then I would get random hot flashes out of the blue.
And tell me what those felt like, especially if they happened, when you were in the middle of work or in the middle of an activity.
Very bothersome because I'm typically a person that never runs hot. So to experience an internal heat that I didn't really understand at that time that was happening to me was a bit concerning. But again, it was so infrequent at that time that I would just kind of be like, okay, this is a transition. But then that transition started becoming a bit more frequent to the point where it did start to affect me a bit more, especially at work with clients as well. And I'd have to take a minute and step back and be like, okay, what's happening here? And fanning myself and turning red and people noticing that, which also led up a whole topic of conversations actually with my own clients, because a lot of them are women of my age as well. And topic of conversation of perimenopause, menopause, the transition, and still learning myself about it, not even thinking about it when this was all happening.
We'll talk about an somewhat unusual symptom that you did have in the beginning as well that started to happen. But while you're on the topic of talking to clients, this is such a common thing where women are talking to other women about it, but it's almost like they just don't feel comfortable or they don't even think about approaching their doctor about it because so many women are being told,
right,
it's just normal, it's just natural, there's nothing you can do, right? Tell me what it was like for you as a business owner to be going to work every day, running a business, making high-level decisions while coping with these debilitating symptoms.
It was very challenging at times, having a sleepless night and then getting myself up ready to go to work and doing something that I love doing and that I'm skilled at, and then sometimes questioning my ability to perform some of my services was very concerning. It was almost like I'd have to give myself the odd time like a pep talk to get through it.
Right.
I did, but it was definitely challenging at times too, for something that would just come very natural to me to start questioning that.
Right. Many women with like this brain fog you described,
Yes.
they say they just don't feel as sharp.
Right.
Right. They're writing things down on little Post-it notes, which they never had to do before.
Yes, definitely.
Did you ever have that thought of like, thank goodness I work for myself? Like, what would it have been like for you to have to work for an employer, right?
I don't know. I haven't worked for an employer for so long, so I don't know.
Right.
Yeah.
So
But-
I mean, I hear from
Yes.
patients, they're told some crazy stuff, like they'll have a giant hot flash in the middle of a meeting, and then their employer
Yes.
will say, you can't do that in the middle of a meeting, like
Yes.
as if they
I've heard
have
stories of
some
that. Yes,
control
right. Yes.
over it, right?
Yes.
So
I've had those in front of my clients too. I've actually had one in front of a client, and we actually had one at the same time together. So we're both sitting there going like this.
just syncing up. How it's
Right?
a bonding
Yes,
experience,
yeah.
I'm sure. Yeah, but it's really, I can imagine it's stressful. You've got the stress
Yes.
of working and running a business and managing clients and managing employees, and then on top of it, there's this really debilitating
Yes.
set of
Yes.
symptoms that you're dealing with.
Right.
And as you mentioned, in the type of work you do, particularly because you had these physical symptoms with your skin, it must have just been really stressful.
Stressful. It was.
Additional stress.
Additional stress, 100%. Yes.
So did you ever hear about, hormone therapy? Were any of your clients using hormone therapy? Or did you feel like you were all in the same boat? Just sort of adrift at sea?
No, there was a mix of people. People were adrift at sea. Some were on it, and I was slowly educating myself on it as well. And I knew it was something that I did want to do, just from my little understanding of it as I was slowly educating myself on it.
It's funny. I feel like more women, more patients are educating themselves right now than even physicians are, which is a whole other thing. We'll talk more about that later. But you also, when you first came to me, you had a very somewhat unusual symptom, or something that people wouldn't necessarily associate with perimenopause.
No.
So do you want to tell us a little bit about what was going on with your skin?
Absolutely. I woke up one morning and I developed rashes around my eyes. Came to see the physician here, a dermatologist here, and we thought it was just eczema. So I was given a topical treatment for that, and then my rash started to extend to around my mouth, and then it slowly progressed to my neck, and then it just progressively became worse and worse and worse. I kept applying the topical creams, and unfortunately nothing was helping.
So finally they did some additional testing, right? Because I think, as I recall, the dermatologist said, we can't get a handle on this. This is really unusual. So what did they ultimately discover was the problem?
So prior to all that, when we thought it was just my eczema, I also kind of tried so many different measures of process of elimination of everything out of my diet, makeup, creams, everything, but still nothing was helping. I was still developing my rashes, which was very cumbersome. And especially with what I do for a living, going to work and doing treatments for people to make people feel good about themselves, and here I am not feeling good about myself, but still, you put your brave face on and you go to work and you do your thing. And I woke up one day with a horrible rash, almost looking like a burn victim, I would say at that time. And called the dermatology clinic here as well, and the dermatologist looked at me and said, "Do you dye your hair?" And I said, "Yes, I do." And apparently now I developed an allergy, and hair color was something that I had been using for years and years, same color, same brand, nothing had changed, but I guess my body was changing.
Right.
And it's funny when I talk to people as well, and I always share my story of that, how it's funny, women of my age group as well, that are starting to experience similar symptoms and similar allergies to things that they never had before.
That's right.
Becoming very sensitive. So I guess hormonally our bodies are shifting and changing.
Yes.
And
we have, as I've said many times on this podcast, you
Right.
know, we have estrogen receptors in almost every cell in our body, including our hair follicles, including our skin. So it's not that unusual, although it's rarely, no one connects the dots, that as the estrogen levels fluctuate and decline, you can develop inflammation and reactions to things, even if you've used them your entire life or
Right.
a majority of your life. So this is, I can understand why it took so long to connect the dots, because sometimes it is simply eczema. But then again, women with underlying eczema or rosacea, that can flare
Correct.
during the menopause transition, and it's not always attributed to it. So I'm really happy and thankful that our dermatologist was able to connect those dots for you and
Me too.
realize that this was your hair dye. And that was around the time you and I
just
first
started
connected.
with you. Yes. So I was a bit of a hot mess just prior to you.
Okay, so I will never forget our first meeting, because I could feel the palpable suffering and desperation, right? Just to use that word, because I just can't think of a better one. I felt like you were really at your wit's end. You desperately needed help. You weren't really sleeping at that point.
No.
You were having so many hot flashes that it was debilitating. And you just felt like you weren't yourself anymore.
Right.
And so we agreed, after reviewing and making sure there were no reasons not to start some hormone therapy.
Correct.
We went through the risks and benefits. And for you, the benefits far, far, far outweighed the risk. And we
100%.
started you on the typical regimen of some estrogen and a progesterone.
Right.
And I remember at the end of that appointment, you asked if you could give me a hug.
I did. I'm a hugger.
No, but it was it doesn't happen every day with every encounter, especially in this world today. We have to be a little bit careful, but I'm a hugger too.
Yeah.
So I was like, of course. And that was one of the most meaningful interactions I've ever had as a physician, because I was just starting the clinic.
Right.
And you were the first patient I saw, literally.
That's right.
And I remember feeling I had finally stumbled onto something that would be very meaningful in my life as well. And it certainly has been. So let's fast forward a little bit.
Sure.
There was a bit of trial and error, as is very common. There's trial and error when we're starting
Of course.
hormone therapy. It
Right.
took us a while to get the right dose, to get the right routine going. But why don't we fast forward 3 months?
Okay.
Tell us what you started to notice happening over that first 3 months on the hormone therapy.
Oh my gosh. Sleeping better. Brain fog was clearing up. My levels of just random anxiety, and I was never an anxious person in my life. That was a hard one for me prior to starting the hormone replacement therapy, for sure. But honestly, everything just slowly went back to normal. And I just feel like me again.
Yeah. And you touched on anxiety, which is really interesting.
Yeah.
So something that a lot of people might not realize is anxiety can also peak.
Right.
And many women tell me it doesn't necessarily have a trigger. So it can be random bouts of anxiety.
Oh, it was. I'd be walking down the street just thinking good things, and then all of a sudden my heart would just start racing and I would become anxious for no reason.
Right. And
Yeah.
others tell me it's things they normally wouldn't have been anxious about. They'll start worrying excessively about
Yes.
things that normally would be, they'll say it was a 2 out of 10 and now it's a 10 out of 10.
Right.
One very interesting thing that I've learned as I've taken this deep dive into learning about the menopause transition is, I'm sure everybody knows the little old lady in their life who no longer drives on the highway, right? And at some point in their midlife, they were overwhelmed and they just decided they couldn't drive on the highway anymore. That's actually an unrecognized symptom of menopause. And it's another thing where they were never anxious before. Nothing necessarily happened. Sometimes they'll attribute it to a near miss or a scary situation, but that normally would have been that 1 or 2 out of 10, and they would have gotten right back on the highway the next day. But it completely puts them off highway driving.
Right.
And it really got me thinking because
Right.
that is a really
That's
common
Yes.
thing.
So common. Right.
But we just avoid it.
Yeah.
We stop that
Right.
behavior that's making us anxious. Really makes me wonder if
Mhm.
if those women had access to good,
Right. Proper
safe
therapy. Yeah.
therapy, would
Yeah.
that have happened?
Yeah.
So it's really interesting because
Yeah.
that's also very, very
Mm-hmm.
common.
Mm-hmm.
And tell us what happened with your skin. Because I do want to point out, so this is multifactorial. We know that as estrogen levels decline, it does have an impact on the skin, right? The
Mhm.
skin loses some elasticity.
Yeah.
It does become drier. It does become thinner. Unfortunately, it's not as straightforward as replacing estrogen. It's sort of a one-way relationship where the loss of estrogen leads to these changes, but replacing the estrogen, it doesn't seem to really solve the problem all on its own. So you worked very closely with the dermatologist
Mhm.
in conjunction with optimizing
Yes.
your menopause hormone therapy.
Correct.
And tell us about the evolution of your skin rashes.
Well, after the course of treatments, my rash is completely cleared, which was great. And I stopped dyeing my hair with traditional hair dye. The main cause of the reactions are PPD, and I'm not going to say the long word of it.
Mhm.
It's parapeptidamine.
Yeah,
or
the
something
chemical,
like that,
the chemical found in,
Yes.
in certain hair dyes.
In certain hair dyes, and we figured that was the main trigger for me. So basically staying away from that. But I took a break entirely from doing it at that point. I had like a day or two where I was kind of like, oh, I feel this is working. But I think the dose that we started me on was, low and slow till we found the proper course of treatment for me, which I did. And then at that point, I'd say, I don't know, within 6 weeks that I'd say I was about back to me.
Yeah, and that's very typical.
Yeah.
So we always start at the lowest dose. The reason being, everybody's estrogen receptors are different. So a 25 microgram dose for you might be like a 50 microgram dose for me.
Right.
And we never want to use, the golden rule of medicine is, use the lowest dose that's effective.
Mm-hmm.
And so we always start low, but also we want to give your body a chance to adjust to it. We don't want to, go too far too fast. So I usually give it 4 to 6 weeks because we know at 4 to 6 weeks, you're seeing the full benefit of that particular dose. And after that point, we increase it step by step till we find that optimal dose. That doesn't mean your body gets used to it and that you'll continually have to increase the dose. We know that everybody sort of has their happy place.
Right.
That can change over time, certainly. But in your case, we found that happy dose where you started to feel like yourself again. And once that happens, you can kind of go back to not having the menopause transition at the forefront of your mind 24 hours a day.
Right.
Like from my understanding of it, you've gone back to your normal active life that resembles what it was
Yes.
at the beginning of this journey.
100%.
Yeah.
100%. Yes.
And so I do want to touch on, I mentioned it briefly, but I do want to reiterate this for anyone listening. But I mentioned you were a very good candidate for menopause hormone therapy. And something I want to explain to the listeners and the viewers is that, like any other medication, we wouldn't treat someone unless they're having symptoms, right? So it's really all about the symptoms. There are a lot of social media influencers out there who are sort of propagating this myth that hormone therapy is for prevention or that it's for, sort of overall wellness and vitality and that everybody should be on it. And that's not true. The same as I wouldn't start everybody on a blood pressure medication unless they have high blood pressure.
Right.
We know that the menopause hormone therapy is most beneficial for people who are experiencing symptoms. Now, that happens to be about 80% of women, right? So we are talking about the vast majority. But what makes somebody a good candidate for menopause hormone therapy is that they are under 60 years of age, that they are within 10 years of their final menstrual period, unless they had a surgical menopause that was done at a particularly early age. Then we can start at any age, up to 60. And then we want to make sure that they are having the symptoms, as I mentioned. So we typically look for moderate to severe hot flushes, which you were certainly having.
Definitely.
But I also put into that category sort of the cluster of symptoms that may not be hot flashes, but are significantly impairing the quality of life and are not found to be caused by any other medical disorder. So if everything else has been excluded, we know it's the menopause transition. Maybe they're having very mild hot flashes, but they're having 5 or 10 other symptoms that are completely decimating their quality of life, and they're otherwise a good candidate for hormone therapy. I think it's reasonable to consider it. The other guideline qualifications are that you have a high risk of osteoporosis or a bone fracture from osteoporosis, or in terms of vaginal estrogen, if you have severe vaginal symptoms.
Right.
So vaginal or urinary symptoms where you're really struggling in that department. Something that I also touch on with all of my patients is testosterone, because that's also another trend out there, right? It's a lot on social media about testosterone being this super wonder medication for menopause, especially for what we call hypoactive sexual desire disorder, right? So everything else is kind of better, but you're still really struggling in terms of, let's just say, libido, right? Testosterone, I want to make it very clear, it's not this wonder drug that's going to fix all of that. In fact, it has to be done under very tightly regulated conditions where it's monitored closely. We keep women in the therapeutic range for a female patient, that they don't go into the male territory and then you start getting some really adverse side effects. I certainly would never recommend you do it through a compounded formula or a pellet, because those tend to be much higher doses than are safe and reasonable. And it's off-label. And what I mean by off-label is it's not part of the guidelines, right? So estrogen and progesterone are part of the guidelines for menopause hormone therapy. But we do know that there are some studies into testosterone, and using a very, very, very low dose, like 1/20th or 1/10th of the male dose of a testosterone gel, can be effective for things like persistent low libido after optimization of estrogen and progesterone. So I just want to bring that point up, because I think it is something that many clients ask me about now off the jump, because they're hearing so much about it. But I think it's a good opportunity just to point out that it's not for everyone. Right. And it's, in your case, in many cases, we make so much progress with the standard therapy that it's certainly not something I would consider on its own or consider from a starting point, if that makes sense. But thank you for letting me sidebar into that. But I 100%. Think it's important, because we get asked about it a lot. So let's take a little bit of a step back. So I'm glad you found me, and I'm glad I was able to help. You too. But I know that I wasn't your first rodeo in terms of approaching physicians asking for menopause hormone therapy, because you'd done your due diligence, you knew about it, you were comfortable with the safety profile. Tell me what happened, sort of, what was that like? What was that experience like?
I did go see a naturopath and was given some natural herb supplements, I should say. And
were those effective?
Slightly.
Okay.
They were.
Yep.
For a period of time.
Okay.
And then as my symptoms progressed, the supplements just stopped working for me. So at that time, then we decided to try some of the bioidentical creams that are out on the compounded creams. And unfortunately,
and let me ask, were you given a full explanation of what you were receiving, how much estrogen was in it?
So what I was prescribed wasn't pure estradiol. It was a different form of estrogen. And unfortunately, I had a bad reaction to that. So after only being on it for less than a week, I had to stop.
What was the reaction that you experienced?
I flushed to a sense that I looked almost very red in my face again. And at that point, I actually went to the compounding pharmacy and spoke to them about it. And they did say that this could be a potential reaction. From my understanding, as I learned it more, sometimes compounded hormones, I guess we don't know 100% what's in it entirely.
Yes, that's right. We don't know most of what's it doesn't come with that insert that tells you all the ingredients,
yes,
right?
Exactly.
So it's unclear what's in it. And it's especially unclear how much of the estrogen is in it, right?
Mm-hmm.
So there is a very interesting study that actually showed that women who received the so-called bioidentical compound estrogen creams receive, in general, a much lower dose, a subtherapeutic dose of estrogen. So it's what I hear most often is women just don't feel much better on it, or it's variable, right? Because you can get a higher amount of estrogen in one batch and a lower amount in the next batch.
Correct.
You don't have a nice consistent level. So sometimes women say, I felt better for a week or two, and then it just plummeted again.
Right.
So that's the really big takeaway is that, remember, for anyone with a uterus, you have to take a progesterone.
Right.
Or a progestogen, a synthetic form of progesterone. They're all synthetic, like they're all manufactured in a lab, but you know what I mean? Like that some variant of progesterone has to be taken to protect the lining of your uterus so that you do not develop uterine cancer. And I'm very, very blunt about this because I've had women say, I don't know the point of the progesterone, I just stopped taking it. If you have a uterus, you need both estrogen and progesterone, but the estrogen is what's doing like the heavy lifting in terms of your symptoms, right? So if you're not getting enough of it, or you're getting a little more, a little less, depending on the day, week, or month, that's really harmful. And so often I'll have women come to me and say, I was on bioidenticals and I just didn't feel better, right? And it's not that the estrogen isn't going to work for you. It's that you really need a consistent, sterile, properly manufactured dose. And then we don't even have to check blood work because we know exactly what you're getting, that it's staying at a postmenopausal level, lower than your ovaries were producing naturally. And it's safe. It's safe for you. So this whole idea of having to, quote, balance hormones or chase something in the blood work, it's not true. In fact, I'd say that's a bit of a red flag. If someone tries to sell you the blood tests and say, we have to monitor this once a month, that is a red flag. Because as you know well, we go based on how you're feeling.
Right, exactly.
Right? Like, what's your response? We knew we weren't at the right dose because you
I
still weren't
symptomatic.
Feeling well, right?
Yes.
Yeah. So now I want to ask you, what would you want to tell people listening that you wish you'd known a year ago?
I mean, I guess that was my own personal journey, but I'm hoping and thinking that more physicians are becoming more acclimated to hormone therapy and the importance of it. So when we do have a conversation with our doctors, more doctors are on board with it. When I asked for it initially, maybe fast forward for somebody else going forward, they won't have that journey of having to wait or try alternative routes in the meantime.
Exactly. And I don't blame anybody for trying what they're trying because the system has set it up so that they really don't have many options right now.
Right.
So yeah, I agree. If at first you don't succeed, try again.
Right.
I don't blame the doctors. It's a system failure that we are not educated in what we were told was based on, 20, 25-year-old data that's been disproven largely in terms of the risks of menopause hormone therapy. I do spend a lot of time in my clinic dispelling those myths. Right. I wish I didn't have to. It's certainly getting easier. The message is getting through. But I think it's interesting. I feel like I'm educating the physicians through the patients.
Right.
So I always tell patients, go back to your family doctor, tell them what you're taking, tell them what we discussed. Maybe that will spark an interest in them. Because in my personal opinion, any family doctor who's comfortable prescribing a birth control pill should be very comfortable prescribing menopause hormone therapy to their menopausal patients. For the right person, it's extremely safe, extremely effective, and it can keep them at work. It can keep them
keeps us vital,
happy and in their family and sleeping well at night. And ward off all of the downstream health effects that come from untreated menopause, like cardiovascular disease, hip fractures, depression, There are things that
100%
that can be done about this, and that 15% of women receiving any kind of treatment, that has to change. And so I guess in closing, I just want to say that this has been a truly inspiring conversation. I know it will spark a lot of discussion out there because we really do have to start discussing this.
We do.
Out in the open.
And I think, I mean, just off topic too, and just speaking with other women too, that, you know, almost lost their marriage going through this, you know, having their children not like them because they were a different person during that time.
Absolutely.
So, you know, just giving us ourselves back, and I think is so important.
Yes.
You know?
Yes.
And, you know,
absolutely.
More studies need to be done on us females.
Right. So I've put together sort of 3 golden rules for patients to take away from this. And I just want your feedback on what you think about these, okay? So the first is educate yourself. Go out there and make sure you're looking at good, well-validated resources like the North American Menopause Society, which is now called the Menopause Society. Their website has a section for patients that outlines the guidelines, the safety profile, and a lot of really, really good information about estrogen therapy, progesterone therapy, testosterone therapy, so that you're armed with the safety data that you need to feel confident. And then the second step is advocate for yourself. Make that appointment with your doctor.
Yes.
They are going to run some tests because they should. They need to make sure this isn't your thyroid, that this isn't any other reasonable explanation for the symptoms you're having, right? Certainly night sweats can happen because of other concerning medical illnesses, and we want to make sure that there's nothing else going on. It's also a really good opportunity to make sure you're up to date with your cancer screening, right? Mm-hmm. You got to get that mammogram, that colonoscopy, and that pap test. It's crucial. You are the concierge of your own health. Nobody else is going to do it for you. Right. But when you're in that appointment, doctor says to you, which is really common, everything's normal. It's just a part of life. You're going to get through it. Just wear some layered clothing and get on with your life. Tell them that this is disrupting your quality of life, that you've done your homework, that you are very, very comfortable with the risks and benefits of menopause hormone therapy, and you would like to give it a try.
Right.
Okay?
100%.
It is well within the scope of a family doctor to prescribe you menopause hormone therapy. If there's someone that's familiar with you, that can follow you, that can, you know, do that regular follow-up care, absolutely, they should be helping you with this. Don't accept it's normal and it's natural for an answer. And the third rule is, if they will not prescribe or help you, ask for a referral. I know the time frames are a little bit long, but get yourself in that queue. If it's an option for you and you're a Medcan client, I of course offer perimenopause and menopause care. I do it as part of a multidisciplinary program where we also offer nutritional support, skincare support, physical training. We have an osteopath. We have a pelvic physiotherapist. So we're able to attack it from all angles because it's a multidisciplinary issue. So it's not just about the hormones, right? But find an answer for yourself so that you can get the help you know that you need. Just don't accept it for an option. I have patients now that are in their late 50s, and so they're kind of getting in just under the wire, but they'll say for 10 years they've been told,
right, you
just have to deal with this.
Right.
And it's I know I sound really, really passionate about it. It's because I am.
Yes,
because
I would be too.
it's just wrong.
Yeah.
It's wrong that we should accept feeling like this when there is such a safe and accessible answer out there.
Mm-hmm. Yes. And so many women, like, as you said too, just are made to feel like they're almost even going crazy and you need to be on an antidepressant.
Exactly.
And that's probably not the case at all.
And what's really interesting is women feel like their antidepressant might not be working as well. And you know what? It's not in their imagination.
Right.
We know estrogen is an important component of serotonin modulation, right? For some women, if they're really sensitive to their declining levels of estrogen, their antidepressant might not work very well anymore.
Yeah.
Just explore, because I do think the patients are going to have to lead the charge. When
and like you said, you know, we just have to be our own self advocates for this and 100%. Not just wait.
And I'm glad that you advocated your way all the way to me.
Yes, me too.
And I'm so thankful.
We need more of you.
Oh my gosh. Well, I'm so thankful
I'm so thankful
to
too.
have you here.
Thank
I
you.
really appreciate you opening up so much about your personal experience, because you're helping take a huge step in breaking the stigma. This is nothing to be ashamed of. This is nothing
absolutely
to
not.
shy away from. We have to put it in everybody's face that this is affecting a quarter of our workforce.
Right.
And that's not counting women who are working at home, which is a whole other conversation. But it's really something that we deserve better as women.
We do.
And so maybe we've taken the first step today in getting there.
So. I think so. I believe so.
Well, thank you everybody for joining us for Eat, Move, Think. I hope you've enjoyed this episode, and be sure to post any questions or give us some feedback of what you might like to see in future episodes. Have a great day.
This podcast episode is intended to provide general information about health and wellness only and is not designed or intended to constitute or be used as a substitute for medical advice, treatment, or diagnosis. You should always talk to your Medcan healthcare provider for individual medical advice, diagnosis, and treatment, including your specific health and wellness needs. This podcast is based on the information available at the time of preparation and is only accurate and current as of that date. Source information and recommendations are subject to change based on scientific evidence as it evolves over time. Medcan is not responsible for future changes or updates to the information and recommendations and assumes no obligation to update based on future developments. Reference to or mention of specific treatments or therapies does not constitute or imply a recommendation or endorsement. The links provided within the associated document are to assist the reader with any specific information highlighted. Any third-party links are not endorsed by Medcan.